Testing, 1, 2, 3, testing. 1, 2, 3, testing.
Good evening. We are live. We're going to give folks a couple minutes to hop on before we get started. Good evening and welcome back to our mental health series here at Living Waters. We are very excited this evening to have Suzanne Martinez, or Sam, with us this evening to be talking about adverse childhood experiences. Sam is the coordinator for congregational outreach for the Office for Mission and Spiritual Care for Advocate Good Shepherd Hospital, Condell, and Sherman Hospital. Sam has been partnering with us all along in this whole series, so we're very excited to have her being the presenter today. So without further ado, I'm going to turn it over to Sam and take it away.
Thank you so much, Pastor. I always feel so welcome being at Living Waters. Thank you. And I'm so grateful that you have decided to join us tonight. I want you to remember that this is an introduction to ACEs, and that's Adverse Childhood Experiences. We're going to be able to look at tonight building self-healing communities. And I want you to make sure that you're gentle with yourself. This is a tough subject, so as we're going through the series, if something strikes you in a particular way, just be able to sit calmly, maybe write a message into the chat for Pastor, because he's right here, present with you, so please don't hesitate just to share feelings or reach out. He is here for you, and so am I. So let's begin. I'm going to take you on a journey. What if the largest public health discovery of our time is about the smallest of us? Next slide. Tonight, we're going to talk about the toxic effects of stress on population as a whole. This will be in the field of epidemiology, and that's what we're going to focus on. Now, epidemiologists are scientists who study the origins of disease, disability, productivity, and health population. They help us to be able to focus on issues and processes that make the most difference for the well-being of everyone. We're going to talk about a particularly large study that had the beginnings, the very beginning of adverse childhood experiences. And that was with Dr. Rob Anda and Dr. Vincent Folletti. They are co-principal investigators for the study of which they call ACEs. Next slide, please. I'm going to share with you the findings from the Adverse Childhood Experience Study. The ACEs study confirms with scientific evidence that adverse early life increases physical, mental, and behavioral problems later in life. This adversity early on has a direct impact. This ACEs study is the largest of its kind, with over 17,000 participants. It was developed and co-sponsored by the Kaiser Permanente. It's a managed care consortium of San Diego, California, and the Centers for Disease Control and Prevention in Atlanta, Georgia. It was done back in the early 90s. Dr. Vincent Folletti and Dr. Rob Anda are the co-principal investigators, and they're going to share and revealed to you, and review how it was approved. Now, I want you to think and remember that the adverse childhood study was done in the early mid-90s, and these two physicians were studying two different areas. One was obesity and weight loss under the Kaiser Permanente of California, and they had a shared question, and one that many health professionals also share. Why is it that some patients, despite their best efforts, continue to engage in behaviors that they know can harm their health? Prior to this study, Dr. Anda's work was on smoking cessation, and he had determined that those who reported anxiety or distress were not more likely to smoke, and they were also more likely to have started smoking at a younger age and having a harder time quitting. This led Dr. Anda and his team to determine if this was a self-medication method for maybe decreasing that feeling of depression or anxiety. So for these patients, the immediate relief of that nicotine effect that cigarettes offer, those symptoms and anxiety maybe were prioritized over their knowledge and had the potentially adverse effects of smoking on their health, but this is looking at it for the long run. Across the country in California, Dr. Folletti now, way across in California, he was studying patients at obesity clinic. And at this clinic, they were going to be losing weight anywhere from 30 to 300 pounds. And it was frustrating up to that point that up to 50% of the patients seemed to drop out of the clinic every year. So this spurred Dr. Folletti to take a deeper look at these patients' medical records. Here, he found a key pattern. It appeared that all the dropouts were born at a normal weight and that they did gain weight, but it was not over a series of years or even decades, but it was rapidly, and then it stabilized. Of those patients who had lost weight, they all had gained it back in a much shorter period than average. It wasn't until he saw another patient who was considering dropping out of the clinic that Dr. Folletti was determined to have an hypothesis around this pattern. In meeting with the patient, Dr. Folletti discovered that she was a survivor of childhood sexual abuse and incest. 10 days later, another patient was going to leave the program and disclose the same. This led Dr. Folletti and his colleagues to interview overall the patients within the clinic. Of the 286 patients interviewed, the mass majority of survivors of childhood and sexual abuse and sexual assault. This was the mass majority. The last piece of the puzzle clicked into place when Dr. Folletti and a patient revealed a year after her rape that she had gained more than 100 pounds. And the patient said, quote, "Overweight is overlooked, and that's what I need to be," unquote. This led Dr. Folletti and his team to a similar conclusion that Dr. Anda's team had determined about smoking, that the behavior pattern they were trying to address, in this case, binge or overeating, was not the problem, but rather a solution to a larger problem. For many, eating was a comfort and soothing to their anxiety and depression the same way smoking did to others. Other patients spoke about how gaining weight kept them safe from their abusers, from the world, and losing weight and becoming healthy increased their depression and anxiety to intolerable levels. It was then that Dr. Folletti presented these findings to the CDC, and that's when he was connected to Dr. Anda, and they decided to pursue their common reflections. These revelations were astounding, that what could be called poor health behaviors, such as smoking, overeating, or drug misuse, were not a result of a lack of willpower in patients, but rather a response to an underlying social or mental well-being of issues. The next slide. Most prior studies of health and social effects of childhood abuse focused on a single type of adversity, such as sexual abuse. The ACEs study broadened the picture to include multiple types of childhood stressors. In addition, the study measured a wide array of health and social problems. This is how the ACE study expanded the knowledge and a broader public health perspective. So in that truest sense, the ACE study is unique because it provides the potential to understand how multiple forms of childhood stressors can affect many important public health problems. The design of the ACE study began early on, and as I shared with you, more than 17,000 persons were involved. They all had an insurance plan. They completed a survey. The survey included health, behaviors, disease risks, mental health issues, substance abuse, other health and social problems, and their ages ranged from 19 to 94. It's important to note that the participants in this study were generally well educated. Most had attended college, and about 6% had a high school diploma as compared to 13% of the US population. They were also predominantly white middle-class people who had access to some of the best health care in the world. Such participants are still being followed to this day in relationship to the ACEs study to determine cause of death, incident of disease, health care utilization, and the use of prescription medications. Next slide. So we're drawing full circle. They came together in an epidemiological study that becomes known as the ACE study. So the team had determined and put together a 10-question survey. And the survey fell into 3 categories. First category, as a child, abuse, physical. And the question read, did a parent or guardian regularly hit, kick, slap, punch, or throw things at you, or ever hit you so hard that you had marks or were injured? Emotional. Did a parent or guardian ever swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid that you might be physically hurt? Third category, sexual. Did an adult or person, at least 5 years or older than you, ever touch, fondle, or have you touch your body in a sexual way, and then attempt other sexual types of intercourse with you? Neglect. Physical. Did you ever not have enough to eat? Did you ever have to wear dirty clothes and had no one to protect you? Or your parents perhaps were too drunk or high to take care of you, or even to take you to the doctor if you needed it? Emotional. No one in your family loved you or thought you were important or special? Or your family didn't look out for each other, feel close to each other, or support one another? As well as household stressors, which was significant because it wasn't just about the immediate individual's experiences of the child, but also the environmental and health, and other members as well. Mental illness. Did you live with someone with untreated or unmanaged mental illness? Or did someone in your house attempt suicide? Domestic violence. Was your mother or stepmother often pushed, grabbed, slapped, or had something thrown at her, or sometimes often kicked, bitten, hit with a fist, or with something hard, or ever repeatedly hit, at least for a few minutes, maybe with a gun or a knife. In many current screenings, it has been modified to include more gender title-neutral languages such as guardian. Substance abuse. Did you ever live with anyone who misused drugs or alcohol? Incarceration. Did a household member ever go to prison? And in many current screenings, we expanded it to determine detained by the state. And this would include those who witness a parent arrest or those who interact with the immigration system, such as ICE and so on. Divorce. Was a biological parent ever lost to you through divorce, abandonment, or some other reason? And I caution you to just be gentle with yourselves. And again, pastors at the ready at the chat. Next slide, please. So here's what they found again. It's important to remember, back to our study, that this population was mostly white, educated, employed, and had access to health care through Kaiser. Now, the first thing they found was ACEs were incredibly common. 60%, I repeat, 60% of the respondents had one or more, and this number had been largely consistent, anywhere from 60 to 75%, reported at least one of these 10 ACEs in follow-up studies with different subject populations. Here in Illinois, the number's around 69% of the participants, adults, had at least one. The researchers found out that 25%, or 3 or more, and 6%, at least 6 or more, here in Illinois, the data is separated by 4 or more, and that about 14% for the whole state, the state as a whole, while in Chicago, it's specifically about 19%. The research also found that more ACEs a respondent had, the more likely they were dealing with the same health behavior issues that doctors Anda and Folletti were treating: higher rates of smoking, drug and alcohol misuse, as well as lower rates of physical activity, poor diet, and all of these seem to correlate with ACEs. They also saw that physical and mental outcomes like diabetes, depression, heart disease, cancer, stroke, and COPD were also more likely because they had an ACEs score. And patients with higher ACEs score were more likely to be dealing with the researchers called social and productivity issues like divorce, unemployment, and less likely to have finished high school or college, and more likely to be involved in abusive relationships. And perhaps the most striking of the research indicated that the impact of the accumulations of ACEs was so powerful that it could indicate risk for a significant drop in a person's lifespan. So much so that those who had 6 or more ACEs were found to be at risk to having a shortened lifespan for about 20 years, less than those who had no ACEs. So if you think about it, the fact that 17,000 persons participated in the initial study, they're still being followed, and more than 25 years later, and 6% of them, recall, they were found to have 6 or more ACEs. So a little over 1,000 people in this group alone, and then the research indicated that those with 6 or more ACEs were found to have a shortened lifespan for up to 20 years. As we continue on this subject, these aren't the only experiences with trauma and adversity a person can have. We know certain populations in diverse neighborhoods face even more trauma than we're able to capture here. So if you think about it, how many more thousands of years of potential life are we losing in a community, in a country, to untreated and preventable trauma? The next slide, please. I would be remiss if I didn't look at the current crisis that we're facing. And in fact, as time moves so fast, we're at a war as we speak of, yet another trauma. I'm not going to go through the statistics. You've lived them, you know them, you can research them, but it's pretty apparent that this very dangerous and deadly disease absolutely is changing the lives of everyone right now, and most likely will continue to do so in the foreseeable future. Next slide, please. So I'm going to take it full circle again. Trauma-informed care principles. This will help to break it down for us, at least in the way that SAMHSA views it as 6 key principles to trauma-informed approach. It's important for us to have a snapshot of the trauma-informed care principles. And I particularly like SAMHSA's, and that's Substance Abuse and Mental Health Services Administration. I particularly like the way they separate these 6 key principled approach. Responses and recognizes the impact of trauma on many sectors in behavioral health and beyond. They're adopting a trauma-informed approach not accomplished through any single particular technique or checklist. And that's what I want you to remember, because we know that it requires constant attention, caring awareness, sensitivity, and possibly a cultural change on an organizational level. An ongoing internal organizational assessment of quality improvement as well as an engagement with the community and its stakeholders will help to embed this approach, and which can be augmented and developed and provide practical and practice improvements. The training provided can help a community be emergency prepared and respond to informed trauma, looking at it through this lens. So we see those 6 principles of safety, trustworthiness, peer support, collaboration, mutuality, empowerment, voice, choice, cultural, historical, and gender issues. That peer support is critically important. Next slide, please. Making a comeback here to Illinois, the number of adults who reported at least one ACE is about 69%. The original study found that 25% had 3 or more, and 6% had 6 or more. Here in Illinois, the data is separated by 4 or more, and that number is 14% state as a whole, while in Cook County specifically, it's about 19%. Next slide, please. This image was modified by Dr. Stan Sanu, who previously at Cook County Hospital, and now he's at Emory University, showcases how we must begin to view trauma, not as a single event in someone's life, but rather as a result of a total experience within systems of a family unit, larger social structures, as well as historical origins, and a systematic oppressions that inform them. And these systemic oppressions keep them informed consistently. So when we're interacting with an individual, whether it's a patient, a family member, a coworker, even friends or family, we're not just interacting with someone in a vacuum at that moment, but rather we're influenced by their total experience as well as those of their family, community, and their history. Whether they be a family unit leading to ACEs or a community traumas such as gun violence, these experiences also cannot be separated from the larger structural and historical underpinnings or the roots and the soil of this tree. When we say historical trauma, we're talking about a cumulative, emotional, and psychological wounding over the lifespan and across generations, emanating from a massive group trauma. This wound can result as a single event from generations of repeated events as well. In the present day, this can manifest for both survivors and perpetrators as structural trauma, emotional, psychological damage from inequity enforced through public policies, institutional policies or practices, perhaps cultural images and behaviors. They're built into the structure of the culture, and they're reinforced by social inequity. So as you go back to the urban study of ACEs in Philadelphia, this study of the population was quite a different than the original cohort. So again, we realized that 80% were white, 38.8% again of those individuals, 36.1 black, 11.4 Latino, 6.2 Asian, and 7.4% of those were Asian. Additionally, questions around adverse community experiences often felt like this. How often, if ever, did you ever see or hear someone being beaten up or stabbed or even shot in real life? Did you ever feel safe from violence in your neighborhood? Did you feel people in your neighborhood looked out for each other, stood up for one another, and could be trusted? How often were you bullied by a peer or classmate? Were you ever in foster care? How often did you feel you were treated badly or unfairly because of your race or ethnicity? Not only was this population more likely to have ACEs, 40% had 4 or more of the original 10, and nearly 40% had 4 or more of the additional community experiences. And these community experiences were found to have a strong correlation to the adverse health outcomes as the original 10 ACEs. Larger, systematic, and historical traumas can have a profound impact on our health and well-being as individual experiences or ideological origins of many of these traumas, such as racism, xenophobia, colonialism, are still very much present in our culture. We cannot ignore the impact they have on health, as well as the systems designed to treat and maintain people's well-being. So again, this study was just the beginning of how our understanding of this prevalent trauma is in the United States and its impact on health. And when we're responding to trauma, we're thinking about how to integrate trauma-informed and responsive policies. We need to look at our organizations. We can't separate individuals and systems of which we live and work with. So we must not only have a trauma-informed framework in mind, but is also one that is informed by equity and justice. The next slide, please. There is a predictable pattern to transformative change. It begins with the discovery of communication, which leads people to clarify their values and their thinking with new knowledge, new habits, and a new way of thinking. People change their actions, and they take it and integrate it in everyday life. These collective actions of many people will help to shape a new reality that is ratified in organizational and policy change. The truth is that people create a new reality long before a law is passed. change is up to us. It is shaped by our thoughts, our conversations, and the way we relate to one another in relationships, in family, and in community. Next slide, please. Supporting healthy communities and processes that respect cultural traditions and values is a high leverage activity. Just as a rising tide lifts all boats, a high capacity community lifts all beings. People living in high capacity communities are less likely to have adverse childhood experience scores, less drug and alcohol use, less depression and serious and persistent mental illnesses, and quite frankly, fewer problems in school or at work. Next slide, please. As we work together to prevent the accumulation of ACEs, I want you to keep in mind that we don't have to have an ACEs score of 0. Bringing scores down to any amount is a huge and important and impactful effects that you can witness. We might not, as a community, be able to prevent the first ACE from occurring in a family, but certainly now you've opened a doorway, or at least a window, to notice when a child can have 5 ACEs and making sure that that number doesn't go to 10. As we thread through all our work, a new focus of supporting adults, and particularly adults who have no fault of their own, have experienced many ACEs when they were a child, we will prevent ACEs in the next generation. Or how about this generation now? We live at a time of great hope and promise. The largest public health discovery of our time, perhaps of all time, is about family. It's about community. It's about children. It's about us. It's about you. Our action to prevent ACEs, whether large or small, can profoundly improve our future. So I encourage you to look for the next ACEs training program. Be that leader in your community that will take a community and bring them together. Look and see what's impacting your community. Draw persons together that can want and feel the need and the desire to make a particular change. And yes, you will be empowered to change generations and to bring that bright light into our future. Thank you so much. I appreciate your time and attention, and I turn it over to Pastor Zach if there's any questions in the chat, or if you have any final questions or commentary. Thank you.
Thank you, Sam. I know I was maybe I shouldn't have been, but I was very surprised by the statistics of 69% having at least one ACE here in Illinois. That's clearly a tremendous need. So this was an overview of the ACEs study and training, etc. If people are interested in doing the full training program, how would they find that?
Well, if you look to the McHenry County Health Board, they're absolutely there. There's training classes. You can look up ACEs as well, and then look for schedule of training classes. And of course, they can turn to you, Pastor, because we're hoping to be able to provide a training class right here at Living Waters. It would be just something that I know that you have a passion for, making that change, being there for your community, and helping to build a brighter future. So please don't hesitate to reach out to Pastor Zach.
Yes, we will endeavor to continue expanding our mental health efforts here at Living Waters for sure. We'd like to do that in the future. Besides hosting trainings, I was curious, what are some ways the communities of faith can help both in caring for folks who have experienced ACEs, but then also helping prevent and try to get those numbers down a little bit?
That's an awesome question. I think the more deeper you delve into ACEs, you're going to realize that you look at people differently. You can use all of your skills. That's your intuition, your collective education that you have, but you start to look at someone differently. You don't look at them in terms of you have a problem, but rather you see that that problem that they're trying to solve has actually made them a hero. They found a way to cope and deal with a stressor that they may not even remember where it came from and when it happened. Because there have been statistics that tell us that it actually can happen even before someone's born. If a mom has suffered a trauma, and ACEs can start formulating right there. So the next time you see someone that's struggling with a particular health issue, just like a healthcare provider, we start to look a little differently. And to be able to open our hearts with compassion and caring and realize the person sitting in front of us is an incredible, amazing person who has survived perhaps a trauma and has found a way to cope. So we're not quick to be able to take that particular situation or problem away, but we look to be able to support them, give them something else to replace it with, and to help them be the best that they were intended to be. Excellent question, Pastor. I hope that you'll close us in prayer because you know that's my all-time favorite. I'm putting you on the spot right now.
Thank you. If there are, let me get back in the camera here. If there are other questions that come in, if you're watching this not live but later, or you would like some of the materials that Sam has provided, we can always send those to you, and we can always forward questions that you may have. We're happy to do that. It's a fun ability that our technology gives us to be able to do this and all. That you can be watching this years from now. We will still be able to do that. Before we do close in prayer, I do want to lift up that next month we will have the McHenry County Mental Health Board with us. Folks from that talking about some of their efforts and services in the area and whatever it is they choose to spotlight for us this next month. So we look forward to that. It will be that second Monday at 6:30 like we have been doing. So please consider joining us for that. Thank you, Sam.
Thank you, Pastor.
Let us close tonight in prayer. Holy God, there's just so much tremendous need in the world. People who carry pain that we can't necessarily detect. We ask that you help us to care for these people. They are us. Surround all of your children with your love, O God. Help us endeavor to take on the systems that cause ACEs to occur. Help us work in ministry and in our daily lives to prevent these events from occurring. Please sustain us in this season with much stress and bring us back safely next month for our continued discussion on mental health. In your holy name we pray. Amen. Thank you. Have a good night.